Mic check. 1, 2, 3, 4, 5. Microphone check. Thank you. Have a good show.
and dignity for older Americans. Pursuant to Committee Rule 7C, opening statements are limited to the chair and ranking member. This allows us to hear from our witnesses sooner and provides all members with adequate time to ask questions. I recognize myself now for the purpose of making an opening statement. We are here today to examine the Older Americans Act, a critically important pillar of our efforts to improve the quality of life for older Americans and their families. In 1965, Congress passed the Older Americans Act, or OAA, to provide basic supports to aging Americans. Since then, Congress has repeatedly updated and strengthened the OAA in a bipartisan manner to fulfill its mission of helping more Americans live independently and age with dignity. OAA programs have been consistently successful, which has led to a gradual expansion of the services it provides. The Act now supports a range of community-based programs that target assistance to those who need it most. Of the many vital OAA programs, one of the most recognized is nutrition assistance, offered through both congregate meal sites and home-delivered programs such as Meals on Wheels. OAA's nutrition assistance programs provide more than 900,000 healthy meals to older Americans each day. OAA also supports elder justice activities and funds programs to prevent elder abuse. Additionally, the Act offers community service employment opportunities to low-income seniors, allowing them to access part-time work that both supports them economically and provides purpose and social engagement. OAA also provides family caregivers with much-needed training, respite, and support. And based on my own experience caring for my 90-year-old mother who has Alzheimer's, I can particularly appreciate the importance of the National Family Caregiver Support Program. Collectively, OAA programs serve about 11 million older adults, 3 million of whom regularly look to OAA services for basic needs. Importantly, OAA programs work together to make sure that aging adults retain independence and avoid costly institutionalized care for as long as possible. Despite the success of the Older Americans Act, in recent years our investment has not kept pace with inflation and has not recognized the rising number of older Americans and the challenges they continue to face. Although the population of Americans aged 60 and over has grown more than 60% since 2001, OAA funding has grown by roughly 20%, and accounting for inflation, OAA funding has steadily declined by 16%. The disinvestment has weakened OAA programs at a time of growing demand for the services they provide. Nearly 1 in 10 Americans over the age of 65 lives in poverty, and they are not getting the support they need. A 2015 Government Accountability Office found that 83% of food-insecure, low-income older Americans did not receive any meal services, and 2 in 3 older Americans who struggle with daily activities received limited or no home-based care. As the number of older Americans continues to increase, Congress must strengthen our support for OAA's proven, long-standing programs. We must recommit to providing basic services and compassionate care to vulnerable members of our communities. Not only is this the right thing to do, but the economics also make sense. OAA allows older Americans to delay or altogether avoid costlier care by promoting healthy behaviors such as chronic disease management and by providing the supportive service that allows seniors to age in place. That is the responsibility and the opportunity facing this committee and the 116th Congress. We are in a position to advance a reauthorization of the Older Americans Act that will allow millions of Americans across the country to age with dignity. This hearing is an important first step. Today we will discuss the challenges facing older Americans, what OAA programs look like across the country, and how the OAA supports millions of seniors and their families. Today, we're also continuing the law's tradition of strong bipartisan support. I was honored to be involved in the 2016 reauthorization when both the House and Senate unanimously supported the legislation. And I look forward to once again working with Ranking Member Comer, Ranking Member Fox, and of course Chairman Scott and all my colleagues on both sides of the aisle to advance a robust Older Americans Act reauthorization bill this year. Thank you to the distinguished witnesses for being here today. I look forward to the discussion, and I now recognize the distinguished ranking member for the purpose of making an opening statement.
Thank you, Madam Chairman, for yielding. Today's life expectancy in our nation is at a historic high, which is great news, and it means we need to be doing all we can to ensure that Americans have access to quality, timely services which allow them to live in their homes as long as possible. This hearing will help us better understand what might be done to ensure the law is aging as well as the people it saves. Since 1965, the Older Americans Act, or OAA, has governed the organization and delivery of services for senior citizens throughout the country. With more than 41 million Americans 65 and older, the social and nutritional programs offered by OAA are critical to helping them maintain independence. The reach of this law is substantial and covers many aspects of elder care. In addition to well-known programs like Meals on Wheels, OAA supports services provided by more than 300 state, tribal, and Native Hawaiian organizations and approximately 200,000 local providers. Some of these services include nutrition programs providing meals at senior citizens, schools, and churches, care to prevent the abuse, neglect, and exploitation of seniors, family caregiver support systems, and community service employment opportunities for older Americans. These types of programs offer valuable assistance for American seniors, and the federal government should continue to support them. I know that I do. As our committee considers reauthorization of OAA, I'm confident that we can work together on bipartisan legislation to support our nation's seniors through effective policy. I thank the witnesses for being here today and hope today's discussion will offer insights into how we can build upon OAA's flexible policies to promote consumer-driven, independent living for older Americans. Madam Chairman, I yield back.
Thank you very much to the ranking member. Without objection, all other members who wish to insert a written statement into the record may do so by submitting them to the committee clerk electronically in Microsoft Word format by 5 p.m. on May 29th, 2019. I will now introduce our witnesses. I'm honored to introduce Lee Gerard, who's the Director of Multnomah County Aging, Disability, and Veterans Services Division, the federally designated Area Agency on Aging, or AAA, for Multnomah County, Oregon, and the largest AAA in the state of Oregon. Multnomah County Aging, Disability, and Veterans Services Division serves approximately 40% of the state's caseload in long-term services and supports. The division operates Older Americans Act programs, state-funded programs, adult protective services, and Medicaid eligibility for long-term services and supports for older adults, people with disabilities, and veterans. Lee has a staff of 465 with 10 community centers and 11 meal sites, reaching more than 136,000 consumers annually. Lee currently serves as the chair of the Oregon Association of Area Agencies on Aging, the member association representing the area agencies in the state of Oregon. She's also a board member of the National Association of Area Agencies on Aging, or N4A. We're going to come back to Ms. Archer-Smith. Next is Christina Grace Juneau Whiting. She's the president and chief executive officer at the National Alliance for Caregiving, where she continues her tenure from previous roles, including chief operating officer and the director of strategic partnerships. Grace led the launch of the Caregiving in the U.S. 2015 research study with AARP and directed the first national public policy study of rare disease caregivers with global genes. She has contributed to several national reports on caregiving, including Cancer Caregiving in the U.S. with the National Cancer Institute and Cancer Support Community, and Dementia Caregiving in the U.S. with the Alzheimer's Association. She is also a member of the American Society on Aging and the Gerontological Society of America. Next, we have Patty Ducaille. She's a licensed master social worker. She became the state long-term care ombudsman at the Texas Department of Health and Human Services in January of 2007. As the state long-term care ombudsman, Patty oversees 28 local ombudsman programs, certifies and trains ombudsmen, and advocates for policy and legislative change to positively impact Texans living in nursing and assisted living facilities. Patty has served on the board of the National Association of State Long-Term Care Ombudsman Programs since 2009, including serving as president from 2014 to 2018. She currently serves as chair of the association's advocacy committee. And Mr. Trone is not here, so Mr. Trone was going to introduce Ms. Archer-Smith, but I'm going to introduce her. She is from his home state of Maryland. Stephanie Archer-Smith is Executive Director of Meals on Wheels of Central Maryland, a community-based nonprofit organization providing congregate and home-delivered meals and support services to individuals primarily age 60 and older through the Older Americans Act Nutrition Program in Baltimore City and County, as well as 6 surrounding counties. Ms. Archer-Smith has 35 years of experience working with vulnerable populations through the life cycle in private, public, and not-for-profit human services organizations. Stephanie has served on the board of directors for the Baltimore Homeless Services and was a contributing author to Journey Home, Baltimore's 10-year plan to end homelessness. We appreciate all of the witnesses being here today, and we look forward to your testimony. Let me remind the witnesses that we have read your written statements and they will appear in full in the hearing record. Pursuant to Committee Rule 7D and committee practice, each of you is asked to limit your oral presentation to a 5-minute summary of your written statement. Let me remind the witnesses that pursuant to Title 18 of the U.S. Code, Section 1001, it is illegal to knowingly and willfully falsify any statement, representation, writing, document, or material fact presented to Congress or otherwise conceal or cover up a material fact. Before you begin your testimony, please remember to press the button on the microphone in front of you so it will turn on and the members can hear you. As you begin to speak, the light in front of you will turn green. After 4 minutes, the light will turn yellow to signal that you have 1 minute remaining. When the light turns red, your 5 minutes have expired, and we ask that you please wrap up. We will let the entire panel make their presentations before we move to member questions. When answering a question, please remember once again to turn your microphone on. I will first recognize Ms. Gerard.
Chair Bonamici, Ranking Member Comer, and members of the subcommittee, I'm Lee Gerard, Director of Multnomah County Aging, Disability, and Veteran Services. Thank you for this opportunity to share our experiences and recommendations for the Older Americans Act as you work towards reauthorization. In Oregon, we have set forth in statute the values of independence, dignity, and choice as the foundation of our work in supporting older adults. These values are also foundational in the Older Americans Act. Area agencies across the nation have worked to build a strong and dynamic network of services and supports that allow older adults to have the kinds of choices we all wish for, living in the communities of our choosing in ways that are responsive to our diverse needs and preferences. When my agency conducted our last area plan community needs assessment, we talked to almost 500 older adults from diverse communities across our county. The need for flexibility in planning local services was highlighted by the variety of needs that were raised in these community sessions. Based on these listening sessions, our agency has continued to prioritize expansion of services for older adults with the greatest economic and social needs, with particular focus on LGBT and racial and ethnic communities in our area. Oregon is no different than the national trend. We now enjoy a longer lifespan than previous generations. By 2025, it is estimated that 20% of Oregon's population will be age 65 and over. Oregon's person-centered system prioritizes the needs of the individual to provide better care, lower costs, and a better quality of life for older adults and people with disabilities. Information and assistance and person-centered options counseling are foundational services within the Older Americans Act. As an individual finds that they need more help to remain independent, these services provide the support to meet that goal. Several recent studies in Oregon have demonstrated the impacts of this work. A recent business case study found an 11-to-1 return on investment for these services. The benefits that were found included finding and keeping long-term services and supports and housing, helping with basic needs to remain independent, avoiding homelessness, which is a growing issue for older adults, preventing abuse, and averting falls and other debilitating situations. A second study also found a distinct correlation between avoiding preventable hospitalizations and the availability of Older Americans Act-funded information assistance and options counseling services. These are significant numbers and demonstrate the high value and return on investment for the services provided via the Older Americans Act. Social determinants of health can influence up to 60% of an individual's health. The Older Americans Act funds health promotion programs, elder justice and abuse prevention, family caregiving support, and nutrition services. It really is this holistic approach that made the Older Americans Act truly ahead of its time when it was created in 1965. As you begin your work on reauthorization, we encourage you to consider important adjustments that could be made to the Act to bring it into this new era of services and supports. We also know that the needs of older adults' experiences can vary widely and be significantly impacted by a variety of factors and barriers. The Older Americans Act is founded on targeting services to individuals with the greatest social and economic needs. We ask that LGBT communities be specifically recognized as one of those populations to be targeted. Local flexibility is also a key program strategy for the Older Americans Act. This provision has enabled area agencies to meet the needs of their local communities in ways that makes the most sense with the most efficient use of funds. Supporting innovation and best practices must also be another key priority. The Aging Network continues to evolve through local planning and development efforts to expand a network of services focused on interventions that lower the overall cost curve in long-term care and health care. Finally, a commitment for bipartisan support to increase authorization levels as well as reauthorizing the Older Americans Act is absolutely necessary to meet the goals of the Older Americans Act going forward. I would like to thank you for your time today and would be happy to answer any questions later from the committee. Thank you.
Thank you for your testimony. And next I will recognize Ms. Archer-Smith for 5 minutes for your testimony.
Good morning, Chairman and Chairwoman Bonamici, Ranking Member Comer, and members of the subcommittee. Thank you for the opportunity to testify today. My name is Stephanie Archer-Smith, and I'm the Executive Director for Meals on Wheels of Central Maryland, a community-based nonprofit that provides congregate and home-delivered meals through the Older Americans Act nutrition program. Each year, we serve over 1 million nutritious meals. 800,000 of those are delivered to the door of nearly 3,000 homebound seniors in Baltimore City and the surrounding counties. Federally supported senior nutrition programs like ours are leading the fight to improve senior health by combating hunger and isolation. This unique combination of nutritious meals, companionship, and other person-centered services is only made possible by the Older Americans Act. Title IIIC of the Older Americans Act, the nutrition program, is the only federal program designed specifically to meet both the nutritional and social needs of older adults in order to reduce hunger and food insecurity, promote socialization, and improve the health and well-being of older individuals. In 2017, the Older Americans Act delivered on that promise to 2.4 million seniors nationwide. The Older Americans Act nutrition program is perhaps the best example of the power of a successful public-private partnership. At Meals on Wheels of Central Maryland, the Older Americans Act funding we receive makes up 60% of our budget. The remaining 40% is comprised of private donations, other private and local government grants, and other healthcare partnership programs. We mobilize more than 1,800 volunteers who provide over $2 million of in-kind contribution annually to support our daily operations. The reality of senior hunger and isolation in our country is sobering. In Maryland, more than 140,000 seniors face the threat of hunger each day, often making difficult choices between eating properly or paying for medication. Nationwide, nearly 9 million seniors struggle with hunger, and almost twice as many live alone, leaving them at risk for negative health outcomes associated with food insecurity, malnutrition, and social isolation. Feelings of loneliness in particular are associated with negative health effects comparable to smoking 15 cigarettes a day. The economic burden associated with senior malnutrition costs $51 billion annually, while senior falls account for $50 billion in medical cost. The good news is the infrastructure to address these consequences already exists through the Older Americans Act network. The majority of seniors receiving Older Americans Act nutrition services report that participating in the program helps them feel more secure and prevents falls, avoiding hospitalization and reducing healthcare cost. 1 year of Meals on Wheels services can be provided for the approximate cost of 1 day in the hospital. In Maryland, the impact is clear. 94% of our participants report increased food security. 98% believe our services have extended the length of time they can remain living at home. 94% report that Maryland Meals on Wheels has improved their quality of life. And 100% report better medication compliance. But it is best illustrated by the story of the seniors themselves. Frederick, who is a 69-year-old Navy veteran, lives alone in a mobile home in Harford County. He's been receiving Meals on Wheels since 2015 because of his limited mobility. Frederick also receives food for his dogs, who are always by his side when we deliver. During his annual home assessment, something all Meals on Wheels clients receive, it was discovered that he had a roof leak so severe that he was no longer able to use his bedroom and mold was growing. Our case management team immediately intervened, identifying resources for his roof replacement. Today, Frederick enjoys his home free of leaks and dangerous mold due to a complete roof replacement, which was finished earlier this month at no cost to him. Ruth lives alone on a narrow street in Baltimore. During a big snowstorm last winter, she wondered how the mobility van that picks her up for dialysis would make it down her narrow street. Despite the snow, her Meals on Wheels volunteer was there. The Meals on Wheels team reached out to the police to ask for their help in getting Ruth safely to her treatment. Ruth shared her gratitude with me, stating, "I thought my life depended on dialysis, but that day my life depended on Meals on Wheels." Were it not for Meals on Wheels, these seniors would be hungry and alone and disconnected from their community. The unacceptable truth is that for these seniors we are unable to serve, this is their reality. A 2015 government accountability report found that 83% of low-income, food-insecure adults are not receiving the meals they need. We currently have 186 people waiting for space on the Older Americans Act funded program. How do you tell a senior who needs your help that you cannot help them? I urge this committee to keep a strong and on-time reauthorization of the Older Americans Act a priority and support local nutrition providers like me as we work tirelessly to meet the unmet needs of seniors today and in the future. Again, I thank you for holding this timely hearing during Older Americans Act Month and for the opportunity to testify. I stand ready to support this process in any way I am able and look forward to answering any questions you might have.
Thank you for your testimony. I now recognize Ms. Whiting for your 5 minutes for your testimony.
Thank you so much, Chair Bonamici, Ranking Member Comer, and members of this subcommittee. Chair Bonamici, thank you especially for sharing your own personal experience as a caregiver for your mother. We need champions like you on these issues. I appreciate the time today to talk about the Older Americans Act Title IIIe National Family Caregiver Support Program. My name is Grace Whiting, and I am the President and CEO of the National Alliance for Caregiving, a 501c3 nonprofit organization dedicated to advancing family caregiving through research, innovation, and advocacy. We believe that OAA programs, including the National Family Caregiver Support Program, support our long-term care ecosystem in 3 key ways. First, healthcare providers rely on caregivers to fill gaps in care, and Older American Act's programs help caregivers become better care providers. Second, employers who face productivity losses due to caregiving can use OAA programs as a resource to help caregivers who are in the workforce. And third, OAA programs can protect the health, wealth, and well-being of aging caregivers themselves. We believe that family caregiving is a public health issue. In national research with AARP, we estimate that there are approximately 44 million people caring for older adults and people with disabilities across the lifespan. That is 1 in 5 Americans, roughly the same size as the population of the country of Argentina. And when supported, caregivers can improve the quality of care offered to individuals. They support activities of daily living, such as helping people eat and bathe, instrumental activities of daily living, such as managing finances, and more than half are conducting medical nursing tasks that would normally be provided through formal care providers. Activities like giving injections, tube feedings, catheters, and colostomy care, often without any prior education on how to do these activities and no prior support. Most help with transportation, which helps address social isolation and allows people to stay engaged in their communities longer. And we know that when supported, caregivers can improve the health of populations and reduce health system costs. When surveyed program participants in the Administration for Community Living program, almost 9 out of 10 caregivers said that these services helped them to be a better caregiver. And more than half said that if they did not have the National Family Caregiver Support Program, the person they care for would be in a nursing home. In fact, if we replaced every caregiver in America with a direct care worker, it would cost our economy $470 billion a year. Healthcare providers are aware of this cost savings, and emerging trends in managed care rely on caregivers to bridge gaps, to reduce health system costs, and to improve shared savings. In our written testimony, we speak to the impact of caregiving on the workforce, including an estimated $36.5 billion a year in productivity losses to employers. Title III programs can help employers offset the cost of caregiving. For example, nutrition programs provide support when a caregiver may not be available to make dinner. Senior centers offer an additional form of respite. Transportation support for seniors can make it possible for caregivers to use that time for other needs. As family size shrink, the number of available people to care is shrinking too, meaning that we must act now to protect caregivers. More than half of the caregivers in America are 50 years old or older. 7% are 75 years old or older. And caregivers of adults with disabilities are aging too. Think, for example, of the aging parents of an adult child with Down syndrome, or the aging wife of a wounded warrior from Desert Storm. Yet the current program only supports 700,000 caregivers. Based on our prevalence estimate, this means that the current program serves only 2% of America's caregivers. One quick personal story before I end. About 6 years ago, I had the honor of being invited to the White House for a ceremony to celebrate caregivers of veterans, the Hidden Heroes Initiative led by former Senator Elizabeth Dole. And I was standing in the green room talking to this caregiver whose husband had been wounded in Iraq, and I said, I grew up in Louisiana, I went to high school in Mississippi. I never in a million years thought that I'd be standing in the White House looking outside at the tourists. And she looked at me at this celebration to honor the work that she was doing for her husband in a room that most Americans are never going to have the chance to be able to stand in. And she said, all I can think about is my husband back at his hotel room and whether he's okay without me. That's the type of person that this program serves. People who are too tired, too overwhelmed, and too busy to advocate for themselves. We know that family is the basic unit of society, and our society needs these families to survive. Thank you.
Thank you for your testimony. And now I recognize Ms. Ducaye for 5 minutes for your testimony.
Thank you, Chair Bonamici and Ranking Member Comer. Thank you to the subcommittee. It's my pleasure to testify today on behalf of the Texas State Long-Term Care Ombudsman Program. Title VII of the Older Americans Act authorizes state ombudsman programs to protect the health, safety, welfare, and rights of residents, people who live in nursing facilities and assisted living facilities. In Texas, over 92,000 people live in a nursing home and over 45,000 live in an assisted living facility. Last year, we resolved 78% of our complaints that we received. That was over 16,000 complaints in the state of Texas. We did that through the use of 100 staff and over 400 volunteers in our program. Today, you recognize the Ombudsman Program and the work we do to prevent abuse and protect residents' rights. And you see that as part of the system to protect independence and promote dignity. Many Americans don't think of an assisted living as a place where you can be independent, but it should be. And many Americans don't think of a nursing facility as a place where you can live a dignified life, but it must be. Our program volunteers and staff are on-site in facilities to the maximum extent possible to ensure that residents have independence and to address instances of indignity. Essential elements of the Ombudsman Program include our confidentiality provisions, systems advocacy, resolving complaints, and preventing abuse and neglect. Confidentiality requirements are specifically outlined in the Act and include strict confidentiality of our Ombudsman program records. So no resident identifying information can be released by our program without the permission of the person to which it pertains. Based on the problems we observe in facilities, our program represents the interests of residents to decision makers in Congress, to state legislatures, and to federal and state agencies. We make recommendations and provide comments, which we call systems advocacy, and aim to improve quality of life and quality of care for residents, most of whom are Medicare and Medicaid eligible. In 2017, state ombudsman programs across the nation investigated almost 200,000 complaints. Complaints ranging from the use of chemical restraints to neglect to insufficient staffing in facilities. But the most common complaint we receive is about discharge. Because a nursing home is a person's residence, a resident has a right not to be discharged without cause. To protect this right, a resident can appeal to the state Medicaid agency, and nursing homes are required to notify every resident and the ombudsman each time there is a discharge. Ombudsmen help residents who want to stay in their home file an appeal and represent them in a hearing. Ombudsmen also negotiate with the facility to find solutions that are other than discharge. So as an example, I want to share you a brief story from Texas. A resident in a dementia unit was issued a discharge notice for being a threat to others. The resident had recently fallen, had limited mobility and vision, and had a diagnosis of dementia. The facility was discharging him for one incident of disrobing in public, which is a relatively common symptom of dementia. His guardian appealed the discharge, and while awaiting the hearing, received a call at 6 p.m. on a Friday night from the nursing home informing the guardian that the resident had been discharged to a behavioral health hospital. The nursing facility refused to take the resident back. So the resident remained in this behavioral health hospital for a month before being transferred to a new nursing facility and living only 1 week longer. While the resident's case prevailed in the fair hearing because it was an improper discharge, the result came too late to benefit him. So the guardian has given us permission to share his story to honor him and to inform you of the effects of improper discharge. To prevent abuse, neglect, and exploitation, ombudsmen train residents, family members, and facility staff on how to prevent, identify, and report abuse. Each on-site visit that we make also prevents abuse. And last 2017, nationwide, Ombudsman programs made over 29,000 routine visits for that purpose. Ombudsman programs also investigated over 5,000 cases of abuse, neglect, and exploitation in an assisted living facility, and over 11,000 cases of abuse, neglect, or exploitation in a nursing home. Thank you for preserving the independence and dignity of older Americans across the continuum. Thank you for recognizing that people who live in institutions and victims of abuse also need dignity and independence. On behalf of the Texas Ombudsman Program and my colleagues around the country, I want to thank you. Thank you for your support of the Older Americans Act, and with it, Ombudsmen will be here in the future and are here today to prevent harm and protect residents' rights. Thank you very much.
Thank you so much to each of our witnesses for your excellent and comprehensive testimony. Under Committee Rule 8A, we will now question witnesses under the 5-minute rule. As chair, I will go first and then yield to the ranking member. We will then alternate between the parties, and I yield myself 5 minutes. Ms. Girard, you discussed research that's been conducted in Oregon regarding the return on investment for OAA programs. I ask unanimous consent to enter into the record the 2018 report commissioned by the Oregon Department of Human Services. So how have you been able to achieve, you talked about an 11-to-1 return on investment you mentioned, and based on this research and from your professional experience, are OAA programs a good investment for the federal government and the taxpayer?
Yes, I would say that they're an excellent investment. The foundation for the return on investment that was studied in Oregon is really person-centered options counseling, and that really entails individuals who have been trained on how to do motivational interviewing and really person-centered care planning, and work with individuals, meet with individuals, and really focus in on their long-term services and support needs, and really develop a very focused plan that's person-centered to what that person and individual needs and the very unique needs that they have. Through the study, what we were able to do is actually do both a qualitative and quantitative analysis, really looking at what were the outcomes that were gained for each individual. And then we used either state or national data around things like if we were shown that we were able to prevent future falls, you can actually cost that out. You know what the cost is when somebody falls and breaks a hip and ends up in the hospital. We were able to show that we were reducing hospital readmissions. We know what the cost of that is in our community. And then able to do other things like helping somebody to avoid homelessness. We know that what the expense is for somebody being homeless. So doing that, we were able to really show that this is a comprehensive service that really helps to connect people to just a wide variety of very person-centered services that results in a significant cost savings.
Thank you for that work. And continuing, Mr. Rod, you discussed tailoring your department's services and supports to meet the distinct needs of individuals from diverse communities, including the LGBT community. We know that LGBT older adults often face structural inequalities, including greater social isolation and higher rates of poverty. But they also encounter barriers to accessing culturally competent aging services and supports, and in many cases are less likely to have supportive family members and more likely to face discrimination. So I want to ask you, and then I'll ask the others, how does your department address the unique needs of the LGBT community, and why should LGBT older adults be designated a population of greatest social need?
Thank you, Chair Bonamici. One of the things that's really a challenge for us locally is that there are not really good data sources and around what is the prevalence of folks that are LGBT in our community, and there is actually a fear for people reporting. So one of the things that we've done is we have a great network in our area. We actually participate in both regional and statewide advocacy coalition to really raise awareness and to really try to identify what the needs are. And one of the things we really have done is we've actually met one-on-one with individuals in our communities. We've done things like we know that there are specific types of social events, so we actually go and meet. We went to a dinner party with a group of folks and really sat down and talked about what are the unique issues and needs that you're experiencing. And when we did some of that as part of our area plan, what we really found was that the needs do differ across different populations.
And what would the designation of greatest social need mean? And I'm going to ask the others as well in the remaining.
I really think it helps to, one of the things that it does is it really focuses our area plan efforts. So we have to it makes us really reach out into the community, hear from communities, and then really be conscientious about how we program for those needs.
Does anybody else please weigh in on the issue? Ms. Whiting, did you?
So I would second the recommendation that there needs to be more research. We know that there's approximately 9% of caregivers in America identify as LGBT, and I've heard from the field that particularly people who are transgendered sometimes feel that the people they care for get worse care from formal providers because of biases. So for example, a gentleman who was transgendered said that his mother received worse care in the nursing facility she was at because the staff was uncomfortable with him and his identity. So I think it's an area that needs more research. We had in our written testimony included some recommendations for OA reauthorization, and one piece of that is to collect more data, in particular on caregiving and these OA programs broadly.
And my time has expired, so I'm going to ask the others to, we'll submit a question for the record. And I now yield to now I yield to Dr. Fox, the ranking member of the full committee, for 5 minutes for your questions.
Thank you, Madam Chairman, and I want to thank our witnesses for being here today to discuss this important subject. Ms. Gerard, I was pleased to hear that you appreciate the value of local flexibility in the Older Americans Act. Can you give us some examples of the differences between services you provide to seniors in Portland versus some of the more rural areas of Oregon?
Thank you, Representative Fox. I think probably a really key example is the provision of transportation. We hear from older adults across Oregon that it's a significant need, but it looks very different in Portland than it does out in places like Ontario or Malheur County. In our area, we have a robust transit system, and we can purchase transportation services through that network. In rural counties, the AAA is the transportation network. So that's probably a really good example.
Great. This question is for all of you, and I'll start on this end of the panel, so you're not always last. One of the purposes of the Older Americans Act is to help people age 60 and older maintain independence in the home. Why is this important, and how does this goal potentially save taxpayer dollars? And do keep in mind there are 4 of you to answer. So,
Well, as the representative of providing services to people who live in an institutional setting,
Right.
I'll make my answer quick to you and say, I know that people want to live in their home and prefer to. There will be a need continuously for long-term care facilities, but emphasis does need to be where people want to get their services at home.
I would say it's in the title of the hearing today. It's about dignity and independence, and our family sizes are getting smaller. We've got roughly I think 1 out of 5 Americans are over 60, and so we want people to be able to thrive and to be cared for by their families in the setting they choose.
Ms. Archer-Smith.
Yes, I would echo that the people that we work with want to stay in their homes and in their communities. They want to age in place. It is more economical to age in your home, and I would argue that intergenerational communities are stronger.
Right.
In our community, only 14% of people getting long-term services and supports are in a nursing facility. The Older Americans Act is the foundation of helping people identify and figure out what additional kinds of resources and services are available so that they don't have to rely on nursing facility services unless it's absolutely necessary.
And let me ask a clarifying question, because I have for years, I think Ms. Archer-Smith, you mentioned that it's less expensive. One of you mentioned it's less expensive for people to remain in their homes. And I've also read over the years that people are healthier, more alert, and generally in better health, and better able to be involved with activities the longer they're able to stay in their home. I'm sure there's associations with having the ability to do it, but also using the facility that you have while you're in your home. The research continue to show that? Any of you can respond.
Especially in Alzheimer's and dementia, where someone who's changing settings but might have mild cognitive impairment, it can be very hard for both that person and the family to continue to care for them.
And I would just add that in Oregon, because we do have such a broad array for people that are often at the same level of need, we're able to show that people can function quite well at home and have pretty significant care needs as long as you have as long as you have a system that supports them.
Great. Thank you all. I yield back, Madam Chairman.
Thank you, Dr. Fox. I now recognize Representative Lee from Nevada for 5 minutes for your questions.
Thank you, Madam Chair, for hosting this important hearing on such an important issue. Having a father who passed away after spending 4 years in a nursing home and now dealing with a mother who is suffering from, is in an assisted living facility, and having experienced her struggles as a caregiver, I think that addressing these issues is incredibly important. And I appreciate the question that Representative Fox just asked about the benefit, tax benefit and financial benefit of allowing people to age in place. I wanted to ask Ms. Gerard, As we know, these supportive services and preventive health programs are essential for older Americans in need of care. And in Nevada, my home state, $3.5 million went to support that. Can you please elaborate on how home health care services can serve as preventive health care for older Americans?
Yes, in Oregon, we've had a foundation of both state and Older Americans Act funded in-home service supports for older adults since 1981. Well, the Older Americans Act actually before that. And we've been able to show that it really helps people to avoid further decline. It helps them to avoid spending down to have to go on Medicaid and use more expensive federal supports, and actually keeps them more engaged in their communities.
Thank you. Ms. Whiting, one of your recommendations was to develop a national resource center for caregiving. Can you explain what the benefit of establishing that would be?
Absolutely, and that recommendation builds on some of the language in the Raised Family Caregivers Act that was enacted last year, which talks about finding efficiencies between different federal agencies. So, for example, there's the VA Caregiver Support Program, there's the National Family Caregiver Support Program under Older Americans Act, there are supports across CMS looking at different types of caregiver supports within Medicaid, home and community-based services models. So the idea here is let's put all that information in one place and make it more efficient for caregivers to navigate across these different centers, as well as identify other community-based supports that might be available to families across the country.
Yeah, that, speaking from a personal point of view, my father broke his hip, and because of Medicare requirements, and Medicaid requirements, was really forced, we quit rehab, which led him to, unfortunately, go into a nursing home. So I find that sort of looking across all of these issues and doing as much as we can to keep someone in home is really important. So I look forward to working with you on that. I wanted to turn real quickly to nutrition. And in Nevada, 80,000 older Americans were deemed to be food insecure in 2016. Estimated by 2025, 17,000 more older Nevadans will need nutrition services than those today, totaling almost 100,000 older Nevadans. And we all know the great work that Meals on Wheels accomplishes carrying out home-delivered services. I'd like to ask Ms. Archer, can you please speak a little bit about the other option, congregate nutrition option, and how it's important to fulfilling the social needs of many of our older Americans?
Yes, thank you. The congregate meal program, as I see it, it's kind of a continuum of service. So the congregate meal program is really good for people who might be able to get to it. Either they have transportation provided for them or they're still a little bit more mobile, so they don't quite need the home-delivered meal program yet. So it's a good continuum of service. That opportunity to socialize with your peers is invaluable. And what often happens is they come for the meal and then they engage in other programs and other activities that will keep them healthier, more mobile, stronger, things like that. So it's a really important part of the continuum of service.
Great. I'll yield the rest of my time. Just thank you all for the important work you do.
Thank you for your questions. And as I'm yielding to Ranking Member Comer, I want to encourage all of my colleagues to do what I have done, which is to deliver Meals on Wheels and to visit a congregate meal site, because I think you'll really appreciate everything that happens there. Now I yield to Ranking Member Comer for 5 minutes for your questions.
And I agree with that, Madam Chair. I've done that as well. Ms. Ducaille, did I pronounce that right? I'm from rural Kentucky. It's hard for me to pronounce a name like that, but so glad you're here. You mentioned the importance of flexibility in the location of a state long-term care ombudsman program. Can you expand on what factors might play into this decision?
Thank you for the question. And yes, I know I have a difficult last name and career name as well. It's hard to pronounce. Yes, so we're in Texas, the State Unit on Aging, a pretty traditional setting for the State Ombudsman Program, and we coordinate with the area agencies on aging in our state to deliver ombudsman services locally. That's a fairly standard practice in many states, but not all states operate in the same manner, and they do so successfully. The flexibility is needed because of different state structures and the different jobs that are done in a state unit on aging or in an area agency on aging, because ombudsman programs need to be free of any conflicts of interest so that we are assured that we are serving the needs of the resident first and foremost, and that none of our work is compromised by the location that we operate within. And so my placement within my state agency, for example, ensures that I have independence from other functions that are performed by the state Medicaid agency, for example, and it works very well for us.
Great.
Thank you.
Great. Ms. Gerard, how do agencies on aging, senior citizens, and other providers of elderly services work together to deliver services?
I think the foundation is we start with our area plan. Every area agency on aging needs a robust area plan that really engages all of the community. And then we actually in our area have an aging and disability resource connection network. And so we really are able to have a no wrong door system. We fund a wide variety of services out in community-based organizations, some of which are culturally responsive, some are culturally specific. And it's really that aging and disability resource connection network that allows the consumer, it doesn't really matter where they show up, we're going to be able to help them.
Great. This question's for everyone on the panel, and as Ms. Fox said, we have limited time, but are there any provisions in the current law or regulations that are particularly burdensome to your efforts that we in Congress need to address this year? Anyone think of anything? Well, I will, before I yield back, I will say this. Of all the government programs that I'm aware of, and there are many, in my opinion, in my district, there's nothing more popular than Meals on Wheels. A very popular district, and anytime there's mention of potential cuts to that, we get a lot of calls and messages in my office on that. So I appreciate everything that you all do, and we look forward to working with you as we continue to try to make life better for you and for the great people that you serve. Madam Chairman, I yield back.
Thank you very much, Mr. Comer. I now recognize Representative Hayes from Connecticut for 5 minutes for your questions.
Good afternoon, everyone, and thank you for having this very important hearing and for you all coming here. I'm struggling a little this morning because I have this lovely binder with these prepared questions, and all I can think about is my grandma right now. And so I really have to shift gears and just go in a different direction just for a minute, if you would indulge me. I was raised by my grandmother. My mom struggled with addiction, and my grandmother raised my brother and I, and really was the backbone of our family. And I would say that, you know, this is over 30 years ago, but in my experience recently as a teacher and even seeing it every week in my church, there's so many aging adults who are over 60 who are now raising their grandchildren. So I know we're talking a lot about, you know, our elderly community receiving care, but there are so many of them that are still giving care. So I guess what I want to first start with, the Senate held a similar hearing last week, and they talked about the National Family Caregiver Support Programs. I guess, Ms. Whiting, has the opioid crisis impacted the rate of aging Americans, especially grandparents, who are having to be the de facto guardians and, in fact, raising their grandchildren?
Thank you for the question. It's incredibly something that's been on our minds as we look out at the field and we interact with people, that the rate of substance use, even I would say other populations such as military veterans, where you have wounded warriors coming home and they're not able to care for their own children, and so sometimes their parents take on care of those minor children. So I think you've hit on something that is critically important and of course is recognized within the Older Americans Act program overall. I would say that some have proposed flexibility and allowing states to put some of the caregiver funding into the kinship care, or the grandparents raising grandchildren, we would just encourage you to think about expanding authorization and appropriations for the program as a whole, because there are many people over 50 who are also caring for other adults and kids with disabilities.
Thank you. And I think that's exactly where I was going, because currently there's a proposed 10% cap on the NFCSP programs that fund older adults caring for children in this country. And I don't want us to get caught up addressing one problem but not addressing the flip side of that problem, because fast forward 30 years and the same grandmother who I just told you was the backbone of our family went through stages of dementia, Alzheimer's, hospice, at home in bed. My aunt didn't leave the house for a year because she had to take care of my grandmother. So I want to make sure that we are addressing all aspects of this problem. It's not just about providing nutrition and supports and getting healthcare services, but really the entire family is affected when this happens. Whether they're the children, who now the only reliable person in their life can no longer care for them, or the adults who are now tasked with caring for their parents and have to put their careers on hold, their families, their lives on hold. So I guess my question, this is the same thing that everyone here has kind of said, how can we provide supports to, what is it that we need to be asking for when we are legislating programs to ensure that we are touching all of those needs and not just pinpointing one area, because I recognize how broad those things are.
Thank you for the question and your personal story. One thing that occurs to me—
Everything's personal here, I swear.
One thing that occurs to me is the need for person-centered services. And the Older Americans Act actually does an incredible job of emphasizing that. But I think there's always room for improvement in terms of how we coordinate those person-centered services across the different Older Americans Act services. So that's something I would recommend to look at and see if that's a point where we could improve upon.
I would also just thank you for your personal story and for talking about that. My grandmother had dementia, and my aunt was her primary caregiver, and it was very difficult for her to access services because some of the restrictions in these laws around ages. So, for example, in the caregiver program, it's caring for people over 60 and then caring for people with dementia of any age, and it's sometimes difficult for people to understand how those programs could be administered. So that's an area where thinking about how the program aligns and making sure people understand at the state level how the program can be administered.
Thank you, Madam Chair. That's all I have.
Thank you very much, Representative. I now recognize Representative Thompson from Pennsylvania for 5 minutes for your questions.
Chairwoman, thank you so much. Thank you for this session. As someone who worked a career for almost 30 years, serving mostly older adults, therapists, previously a licensed nursing home administrator. The Older Americans Act is incredibly important. I was pleased when a few years back here, we did the last reauthorization. We made some really good improvements, tried to focus on some of the chronic and disabling conditions. Did some investments in our senior centers, a lot of good things, but this is the reason we do periodic reauthorization, so we make sure that we're always getting it better and getting it right. And so, and thank you for what each of you do and the perspectives that you bring here. One of the this was mentioned briefly, one of the covered populations under the Older Americans Act, obviously, are those who are living with Alzheimer's disease. Experienced that. My mother lived with Alzheimer's for 10 years, stole her identity, her memories, and in her life eventually. These individuals receive the vital care and assistance needed to help maintain their independence. However, there's an estimated 200,000 Americans under the age of 60 that are now living with Alzheimer's disease, or more commonly referred to as early onset Alzheimer's. Kind of an area I worked on when I practice rehabilitation. Now, those with early on Alzheimer's face difficult challenges when it comes to family and work and finances. Things kind of compound. It's almost like an accelerated aging to some extent. Starting with Ms. Whitting, what are your thoughts as we look forward to reauthorization? And I know that we've got an age group of 60 that we define for the Older Americans Act, but quite frankly, when you look at things like Medicare, we do make accommodations for certain disabling conditions, end-stage renal disease, or maybe more. Where folks are younger than that normal eligibility age. Any thoughts on what we should do in terms of early onset Alzheimer's? Any revisions or thoughts for changes as a result of the next reauthorization of the Older Americans Act?
So under the current Family Caregiver Support Program, my understanding is that if you're caring for someone with Alzheimer's or related dementias of any age, that you can receive services. But I would say when we look at other places in the federal government where they're providing support to caregivers, this is an area that is definitely underserved. So, for example, there's an estimated 5.5 million people caring for military veterans, and the support for those programs is over $1 billion. Likewise, with Alzheimer's and dementia, that community was able to reach an appropriation and authorization level to support it. I think the other piece, though, is just looking at research and where is it that we don't know what we don't know.
And there is an early onset bill that's been introduced in the House and the Senate that I think would be perfect to incorporate into any future Older Americans Act reauthorization. I want to kind of revisit just briefly to anyone that wants to comment further on the whole issue of just everywhere I go, obviously the public health crisis of our lifetime is substance abuse. Maybe it's opioids, maybe it's crack, maybe it's prescription drugs. It changes based on a host of factors, but it's the underlying substance abuse and tremendous number of I don't want to call them older adults because I'd put myself in that category of grandparents who find themselves now back in a primary care role. And there's a reason we have our kids when we're younger. We have the endurance for it. And when to assume those roles, in your 50s and 60s and 70s is a challenge. And so I heard some general responses, but are there any concrete, any specific at this point recommendations that you would have for? I'm not one that just likes to throw money into a program and hope that good people do good things. I like to have clear direction, and maybe it's more study that we need to do to figure out what are the supports that folks, I guess technically be 60 and older because of the Older Americans Act, of what we could, how can we help those grandparents that find themselves in a parenting role once again?
Yeah. That's a really, really great question. I think there are some really good evidence-based programs that some communities are really starting to utilize that are helping to destigmatize and bring resources for older adults who are experiencing both many behavioral health issues, including substance use disorders, because they're often co-occurring with other issues. And I know in our state, we've actually been looking at studying what some of the barriers are for people getting the supports that they need. And it is actually more challenging for somebody that is older, somebody 65 and older, to get the supports that they need because of issues around how Medicare is structured. So if we can be looking at ways that we can use evidence-based programs, that we can use peer supports, where peers can actually support their other people that are going through the same thing, I think that would be excellent.
Okay. Thank you, Madam Chair. Yep. Well, actually, let me just say, if any other witnesses have any thoughts or inputs of specific strategies, if you wouldn't mind forwarding to the committee, I think that would be very helpful. How do we help these grandparents who find themselves in?
Yeah, Representative Thompson, if you put that in writing as a question for the record, we'll make sure that that happens and we have a full record. Thank you. Now recognize Representative Trone from Maryland for 5 minutes for your questions.
Thank you, Madam Chairman. Thank you all for coming out today. This is a really important subject, and I want to talk a little bit about social determinants of health, SDOH. It's a new term in health. I wasn't that familiar with whatsoever. For the Older Americans Act has been way ahead of the curve in recognizing the importance in addressing the social determinants of health through community interventions. Category under the SDOH that's starting to get more attention is loneliness and social isolation. It's a growing concern and one that has serious health consequences. 2010 study at Brigham Young University found loneliness can shorten a person's life by 15 years. Another at Rush University found connections between loneliness and a whole wide range of health problems, especially increased risk of Alzheimer's. So, Ms. Archer-Smith, first of all, I want to thank you again for coming out. You're work in my district and Montgomery County, so it's great. You serve over 40,000 seniors throughout Maryland, and we really appreciate the help with Meals on Wheels. But a quarter of our seniors are living alone. And, I know the fantastic volunteers are serving many of these seniors nutrition, and that's the only human interaction they get often. And those connections are so important to have, during the day. So you spoke about the benefits of home-delivered meals and reducing isolation among these homebound adults. Can you share some examples of individuals who particularly benefit from social contact provided by the program and how this program is doing more than just substance, but performing other duties in isolation?
Yes, and thank you for the question. So I can give countless examples of volunteers who tell us about the person who they wait for the end of the route so that they can spend more time with them, play cards with them, talk with them about what's in the news. I can share with you a personal experience that was in my written testimony of a woman named Doreen who was 92 years old and lived alone. And I actually delivered to her personally. And I was covering for someone, and I like to do that periodically to, engage with our clients. And she didn't know me when I came in, but her face was so excited to see me, and her eyes lit up so wide, and she wanted to know everything about me. What was my name, and what did I do at Meals on Wheels, and why was I there today, and where was her other volunteer? And those are the questions. She was just hungry for someone to talk to. And I think that's that's true of many of the people that we serve. But many of the things that we do, we call ourselves more than a meal because we're delivering more than just a meal, and that goes beyond that interaction with the volunteer. We also have other services that act as other touch points for them. So if it's a companion visitor, or if it's a phone pal, or something like that, that's another touch point. If it's someone to help them with some grocery shopping, the household things that we don't deliver, those are other touch points, and those are opportunities for them to interact more. And we have many, many stories of people who receive our full offering of services.
Yeah, I was with a friend of mine last night. He's worked with Meals on Wheels for probably 4 or 5 years, and he had a lot of similar stories about, saving one person toward the end of the route to spend some time with them and one-on-one, and that made their day. So I think it's really great work that you guys are doing. What are the limitations that you're facing right now to be able to cover everybody appropriately, and what are the barriers?
So the barriers obviously are funding. I mean, that's the easy answer. But there are so many other things that our clients need. So being able to create those services and a plan for them that is unique to their individual needs is important. So being able to be creative about how we can deliver those services, whether it's grocery shopping through volunteers or companion visits, or whether it's professional case management and care coordination services.
And what is your volunteer stream? Do you have an adequate number of volunteers?
We have an aging group of volunteers, so we have some very, very loyal volunteers that have been with us for many, many years. And so we're able to recruit a lot of volunteers by way of word of mouth because they're so loyal to us and they tell their friends about it. But we are struggling to keep volunteers with growth. So there needs to be a more intentional approach with that, which we are addressing.
Well, it's very rewarding work. Thank you.
Thank you.
Thank you, Mr. Chairman. I now recognize Mr. Johnson from South Dakota for 5 minutes for your questions.
Thank you, Madam Chair. Ms. Dukayet, maybe start with you. Of course, as we talk about reauthorizing the act, we want to make sure that it's well-positioned for the future. I feel like I've read in a number of different places that the number of older American seniors will double like in the next 30 or 40 years. And I think despite our best efforts to help people age in place, I assume that will mean a lot more folks who will call nursing homes, long-term care facilities home. Number one, is my assumption right about the data from what you know? And then number two, will that place a burden on the ombudsman, ombuds people across the country?
Thanks. Yes, so absolutely, we know that the numbers are really skyrocketing in terms of our aging population, and that is going to affect our need for long-term care facilities. Where we're really seeing the biggest boom, and it's really been happening for decades now, is in assisted living facilities. Sure. If we can make those affordable everywhere, and that is a big question in all states, then people will choose assisted living facilities instead of nursing homes if they can at all possibly have it. It gives you more freedom and independence. It's less expensive to provide services in that setting. That boom has completely overwhelmed our ombudsman programs across the country. And so we hope to see a new appropriation for us to serve people in assisted living facilities, frankly, because we've never seen that given to us in reauthorizations before, and we have been very overwhelmed by the addition of assisted living facilities to our responsibilities.
Yeah, and of course, resources are a big part of the equation. I mean, nationally, do we see a change in how services are deployed in a way that provides for more efficiency or effectiveness in meeting the mission?
Well, I think big states like mine tend to use localized services and don't have a state operation hub for all services to be provided, and that makes sense for us to have localized offices of our program so that we can get to the residents quickly and visit facilities frequently. We need to use volunteers, and we are allowed to use volunteers. That's a cost savings to the government. And volunteers do a lot for our program, but our volunteer workforce is aging as well. And that has been a challenge for us too, as we need to replenish those services. So another thing that would help the Ombudsman program with volunteers is to be able to recognize the role of the volunteer more specifically in the Act, be able to reimburse volunteers specifically for mileage costs and training costs that are associated with it, because volunteers save money for the Older Americans Act, but it isn't entirely free to have a volunteer in your program either. You've got to have a well-trained force.
So I just want to make sure I'm tracking more specific language, making it clear that those volunteer expenses could be reimbursed as a part of the program would be helpful.
Yes, it would.
Okay, very good. So then, Ms. Whiting, as we look at, we talked about aging in place, and I thought you did a nice job of outlining the value proposition when we have effective caregivers that allows people to maybe put off going to a long-term care facility or assisted living. So a similar question, if we have this many more older Americans in the future, and you mentioned that we're only providing supports to 2% of the caregivers out there, are there ways that we should be looking nationally to deploy services in a different way that can help meet the goals, meet the mission?
I think, Congressman, the ultimate goal here is that we would have people taking care of each other and would be fostering that, not just through the appropriations process and expanding the program, but just to bring to your attention, the Raise Family Caregivers Act Advisory Council has yet to meet, and it's on a 3-year sunset and will end in 2021. And that council, proposes an opportunity to examine those exact kind of questions. And so we would encourage you to think about extending the life of that so we can actually get a plan that has employers, providers, older Americans, and others putting in what they really need and where there could be more efficiencies in the system. I think the other piece of this is, if I can respectfully call it, the Golden Girls model, where we have peers living together, because increasingly we have younger generations of caregivers who are not having as many kids. They are more isolated, and so how can we help people age in healthy ways using things like respite and senior centers and these other types of OAA programs so that they can care for each other as peers?
Yeah, so, and then Ms. Archer-Smith, Ms. Gerard, I just wanted to give you an opportunity briefly to comment on anything as we're talking about increasing number of seniors and if there are different deployment mechanisms to provide supports, allow for aging in place. Any other thoughts?
Well, I don't know if it's an opportunity. It's definitely a challenge. One of the things that families need is they need respite care, and they actually often can be a better caregiver if somebody else is coming in to do caregiving, like giving somebody a bath. And what we're really experiencing is a challenge in the availability of a workforce. So I think workforce development for people so that there are people that view this as a viable option for them for employment would be really, really beneficial. And I know that there are both many state and national efforts looking at workforce issues, but that is going to be a big one.
Thank you very much, Madam Chair. I yield back.
Thank you very much. I now recognize Representative Stefanik from New York for 5 minutes for your questions.
Thank you, Chairwoman, and thank you to our panelists for being here today on such an important topic. I represent New York's 21st District, which is one of the most rural districts on the East Coast, but it's also one of the most aged districts if you look at the percentage of seniors that I represent. So your programs and the great work that you do has a direct impact on my constituents. I wanted to follow up on Mr. Thompson's line of questioning related to Alzheimer's. As we know, there are approximately 200,000 Americans suffering from early onset Alzheimer's disease, and too often people living with this disease in their 30s, 40s, and 50s can have young children, new homes, or growing careers. They are shut out of vital services just because they're young and the disease hits them earlier. Alzheimer's forever changes people's lives. It's impacted my family, and we've heard from stories on both sides, both individuals in the audience here today, witnesses, as well as members of Congress who have been impacted. I introduced the Younger Onset Alzheimer's Act this year. That was the legislation Mr. Thompson was referencing. That would amend the Older Americans Act to ensure the availability of programs and services for those impacted by Alzheimer's by allowing patients younger than 60 to access them. So my question, Ms. Whiting, is this legislation would allow the National Family Caregiver Support Program and the Long-Term Care Ombudsman Program to serve this population, but can you shed more light on how expanding these programs to those under the age of 60 would greater support family caregivers, especially those in the workforce or those caring for young children? I'm really interested in the caregiver piece aspect of this.
Thank you for that question. I think Alzheimer's is probably one of the biggest threats to, for lack of a better word, facing us. And in particular for caregivers, we know from research that it impacts their health, it impacts their ability to stay engaged in the workforce, and we know that employers are starting to think about the impact of Alzheimer's. So actually, in Kentucky, the ranking member's home state, the Louisville Healthcare CEO Council has been trying to come up with business solutions for caregivers at work. I think where Older Americans Act programs can be most helpful to people with Alzheimer's, one would be respite, expanding availability of respite. The second is, really being a state laboratory to test Alzheimer's interventions that work. So, for example, the REACH intervention is an amazing intervention in New York. Mary Middleman's program that she's done, hospital to home, that helps educate caregivers at discharge is also an excellent program. So thinking about how the AAA network can test that in different types of communities and then use that to spread those best practices.
Thank you. Ms. Gerard, I wanted to follow up on your recommendation about workforce development when it comes to caregivers. The issue of caregivers is something that not only I've engaged on this committee, but also on the House Armed Services Committee when it comes to military caregivers. There was a program through the VA for military caregivers, but they did not anticipate just how many applications there would be, so it was underestimated. You talk about workforce development specifically for caregivers. What can we do to ensure that we have a trained, qualified, and well-paid workforce when it comes to caregiving?
That's a really great question as far as what's kind of infrastructure is needed. I think we need to be looking at making sure that it's seen as a viable career, that it pays a living wage. That can be a challenge where sometimes the caregivers, the in-home caregivers are actually receiving public benefits. So the more we can promote a living wage for folks where they might be able to get some benefits, And I know I had the opportunity to be on our Oregon Home Care Commission, and they really have developed statewide a strategic plan. So I think encouraging communities to develop strategic planning that really looks at their workforce and how they can really boost it, because really we're funding that workforce in our area through both Medicaid, through state funds, and Older Americans Act funds. So, and it impacts really in all the individuals getting those services. So it's a real vital thing.
Absolutely. Any other feedback on those questions from other panelists? Ms. Archer-Smith?
Yes, I would just encourage the reauthorization at levels that help meet the unmet need, because when you are providing the meal for the person with Alzheimer's, you are supporting that caregiver. When you are bringing other resources into the home, you are supporting that caregiver. We have stories of, people that we've been able to help navigate a very complicated system of resources that are out there. And without the support of a case manager or a client support specialist, they may not have known how to get those extra hours of in-home care that they were eligible for. So making sure that we're meeting the unmet need is serving both the participant and the caregiver.
Thank you. My time has expired.
Thank you. I now recognize the chairman of the full committee, Representative Scott from Virginia, for 5 minutes for your questions.
Thank you. Ms. Whiting, I wanted to follow up on one of the things. You talked about respite care. Can you talk about the value of respite care both to the senior and to the caregiver?
Absolutely, and thank you for the question. So respite care is one of those evidence-based benefits that we know improves the ability of the caregiver to actually be a provider of care, and it provides the individual who's receiving care a chance to essentially take a break. I mean, one of the challenges is we think about caregiving in these real tactical terms, but there's research coming out that shows that if you can improve the relationship and the way that the caregiver and recipient communicate with each other, you can not only improve the health of the older person or the person with disabilities, but you can improve the health of that caregiver as well. So being able to give people a break from each other and a chance to just be the sister, the wife, the brother, the friend, has a tremendously positive benefit on families.
Thank you. Ms. Gerard, you talked about the cost of caregiving. Is it realistic to think that you could provide funding for caregivers without subsidy?
Well, I do know a good example. I'm probably actually am a good example because I'm doing caregiving for my father. He lives about 30 miles from me, and I have been searching for a caregiver that I'm willing to pay in my community, and I can't find anybody. So, so it's a struggle. I mean, there are many families who are willing to cover the cost of that. And especially when you look at a return on investment of they get a break, if you can have somebody come in 5 hours a week to just do some of the really heavy work. So I think looking at how we can encourage families to do that, individuals to do that, but then also I do think we have to look at a bit of a safety net for people that really can't afford to pay for caregiving. And if you look at the return on investment,
if you're going to pay the caregiver a living wage, most of the seniors can't pay someone else a living wage because they're hardly making it themselves.
That's true. So that's where really we do have to subsidize that. But if you look at the cost of the in-home caregiving and compare it to the cost of either a community-based care like assisted living or a nursing facility, it's still much, much cheaper. We have some state-funded programs where it's really only costing the state and Older Americans Act actually about $300 a month. But if that person was in an assisted living, it would be probably $3,000 a month, and if they were in a nursing home, it would be closer to $6,000 to $8,000 a month. So there is, if you look at it that way, it's actually very cheap.
Thank you. And the Older Americans Act supports a number of evidence-based health interventions. Ms. Gerard, one of these is fall prevention, where evidence shows that fall prevention programs can reduce problems. Can you say a word about that?
Yes, for our area agency on aging, we look at the development of those programs at multiple levels. We participate in a network that includes us, it includes public health, it includes healthcare providers, and it includes our community partners like our nutrition programs. We develop a plan in our area, and then we look at different ways that we can all pool funding to start really developing a network of fall prevention programs, evidence-based fall prevention programs. And some of the funding is coming from Older Americans Act, but some of the funding is coming from other sources. And we really try to embed it in local community-based organizations, because then it's more likely to get out to the folks that actually need it.
When you talked about evidence-based, do the fall prevention programs prevent falls?
Yes, the evidence-based, they've been studied. They've been compared to control groups where people have not been getting the program, and has shown a really significant return where in reduction of falls. And I know that in our area, falls is actually, for older adults, is one of the biggest disease, injury kinds of issues in our county. So it's something that our whole health network is really looking at.
Thank you. And finally, Mr. Duque, can you say a word about the ombudsman model addressing problems of elder abuse?
Yes, thank you. So I would say that our model includes surprise visits, frequent visits to facilities where our eyes and ears are in those buildings, and I think that absolutely prevents abuse. It is something different, far and away from a regulatory function that is there to cite a facility and bring them into compliance. Our focus is on the resident and being person-centered and finding a resolution that the resident wants and seeks to feel safe and secure after abuse, neglect, or exploitation. I think those are really key factors. We resolve 73% of complaints to the satisfaction of the resident or the decision maker of the resident every year.
Thank you. Thank you, Madam Chair.
Thank you, Mr. Chairman, and I see no other members. I want to remind my colleagues that pursuant to committee practice, materials for submission for the hearing record must be submitted to the committee clerk within 14 days following the last day of the hearing, preferably in Microsoft Word format. The materials submitted must address the subject matter of the hearing. Only a member of the committee or an invited witness may submit materials for inclusion in the hearing record. Documents are limited to 50 pages each. Documents longer than 50 pages will be incorporated into the record via an internet link that you must provide to the committee clerk within the retired time frame, but please recognize that years from now, that link may no longer work. So again, I want to thank the witnesses for their participation today. What we've heard is incredibly valuable, and I know members of the committee may have some additional questions for you. We ask the witnesses to please respond to those questions in writing. The hearing record will be held open for 14 days to receive those responses. And I remind my colleagues that pursuant to committee practice, witness questions for the hearing record must be submitted to the majority committee staff or committee clerk within 7 days. The questions submitted must address the subject matter of the hearing. I now recognize the distinguished ranking member for his closing statement.
Thank you, Madam Chairman. I just want to again thank the witnesses for being here today, and thank you for everything that you do and the people that you serve. Your knowledge and experience and testimony today will help us better serve older Americans as we move forward. It's crucial that we hear from people on the front lines like yourselves, and I think this committee hearing has been very beneficial to us. We must acknowledge the challenges facing the Older Americans Act, given the rapidly growing senior population and constraints of a limited federal budget. As we explore ways to further empower seniors, we must enhance coordination within the program to effectively serve those with the greatest social and economic needs. A critical aspect of this is maintaining and strengthening the local flexibilities within the law to meet the needs of individual communities. We have the opportunity today to begin the committee's process of improving the law to better provide care for older Americans. Again, thank you for being here today, and I look forward to working with you in the future. Madam Chairman, I yield back.
Thank you. I now recognize myself for making a closing statement. And thank you again to the witnesses for providing such insightful testimony. And I think I also want to thank my colleagues who shared, and you heard the intensely personal stories, because this is an issue that affects us all and affects our constituents. People in the United States of America should be able to retire and age with dignity. And by passing the Older Americans Act in 1965, Congress did make a commitment to provide Americans the support they need to age independently in their homes and communities for as long as possible. And today, as our witnesses testified, the Older Americans Act programs empower millions of adults every day to remain independent while avoiding or significantly delaying a costly institutionalized care. The population of older Americans continues to grow, but unfortunately, investments by Congress in OAA programs have not sufficiently kept pace, and this has reduced our ability to meet the increased demand for these effective and widely used services. Just Monday at home in Oregon, I heard about an 80-year-old woman who was living in the backseat of her car. And I think far too many Americans continue to live in poverty across our districts, face discrimination, face barriers to basic necessities, in part because OAA programs are underfunded and not well enough supported. So today's hearing has underscored our responsibility. We can help stop this cycle of disinvestment, which is eroding the original purpose of the Older Americans Act and creating additional challenges for too many older Americans and actually costing us more in higher cost care. As this committee considers the OAA reauthorization, I hope we can work together so its programs have the support and resources needed to provide essential services and compassionate care to all aging Americans. Just 3 years ago, both parties came together in each chamber of Congress to reauthorize and improve the OAA programs. Today, I appreciate my colleagues joining me in renewing that commitment to honoring the promise made to older Americans more than a half a century ago. By continuing the Older Americans Act tradition of bipartisan support, we can make clear that this committee and this Congress will continue to stand up for older Americans. So thank you again to the witnesses for being here. I look forward to working with you and all of my colleagues on both sides of the aisle as we move forward. And if there's no further business, without objection, this committee stands adjourned.